Thank you so much for the kind introduction. And I think my topic has been covered by all the doctors here, Dr. Rita, Dr. Ashish, and everyone. And so today I'm going to talk about the NAFLD and CV risk. So non-alcoholic. So can I do this? So we're going to talk about the NAFLD and CV risk. So as we know, the introduction, NAFLD is also known as noun MAFLD. It's a progressive disease encompassing the liver steatosis, non-alcoholic steatohepatitis, fibrosis, and cirrhosis. And it's a ectopic deposition of triglyceride in the liver. The prevalence varies with the age and race and ethnicity here. So the term NAFLD emphasizes the bidirectional relationship. Patient with type 2 diabetes and CV disease or its risk have the possibilities of NAFLD or vice versa. Some of the well-established risk factors for NAFLD include type 2 diabetes, obesity, dyslipidemia, and metabolic syndrome. And various large population studies have identified the NAFLD as an independent risk factor for NAFLD. CVD. Currently, CVD is the most common cause of death in patients with NAFLD. It is a major cause of CLD and the main underlying cause of liver transplantation within the 10 years. Due to lack of awareness, screening, referrals is underdiagnosed, leading to low primary care and non-hepatology specialties. It is also associated with increased liver-related morbidity and mortality, but also increase the mortality due to cardiovascular disease and cancer. And talking about the epidemiological data, it has been covered. And moving ahead, I will not going to talk about much about the pathophysiology and mechanism. So we have the genetic factors, CV risk, gut microbiota, leading to the non-alcoholic fatty liver diseases, which increases the pro-inflammatory molecules, procoagulase states, and insulin resistance, leading to increase the risk of CV risk. So moving ahead, what are the cardiovascular risk? And so we have the impact on the cardiovascular system, which will reduce the ejection fraction and preserve ejection fraction. Most analyses have found that NAFLD has a 64% reductions in the cardiovascular events, especially with the NAFLD patient. Additionally, NAFLD patient have type 2 diabetes have higher risk of CV events, which increases the risk of CVD events, particularly in the patient with NAFLD or type 2 diabetes. And we have the NAFLD and arterial hypertension, the most common modifiable risk factor. So WHO estimates the high blood pressure accounts for 54% of all cause strokes and 47% of ischemic heart disease. It also increases the risk of heart failure, peripheral artery disease, and arrhythmia, especially AF. Among the patient with non-alcoholic fatty liver disease, the prevalence of arterial hypertension ranges from 40 to 70%. So NAFLD and arterial hypertension significantly increases the risk of developing prehypertension and hypertension. In France and Germany, NAFLD patients have 2 to 3 times higher incidence of hypertension. Research from Finland indicates that NAFLD is associated with high blood pressure levels, great blood pressure variability, and often linked to reduced baroreceptor sensitivity. And perivascular adipose tissue around the coronary artery promotes the inflammation and closely linked to coronary artery disease, which explains the NAFLD is associated with increased marker of subclinical atherosclerosis like coronary artery calcifications, increased coronary artery calcium scores independent of traditional CVD risk factors, which increases the risk of carotid artery intima media thickness, plaque, arterial stiffness, coronary artery calcifications, and endothelial dysfunction, leading to the many cardiovascular risks. So meta-analysis has found that NAFLD patients with have significantly higher risk of clinical coronary artery disease, and it predicts the high-risk coronary artery plaque, increasing coronary artery events. In the study of 360 SCMI patients, those with NAFLD have higher in PUB hospital and 3-year mortality rates than controls. And it increases the arrhythmia, such as AF and ventricular arrhythmia. Low-grade inflammations and increased pro-inflammatory mediators can affect the heart, prolonged QT intervals and QTC durations. Insulin resistance common in metabolic syndrome may decrease the potassium levels, further affecting the heart repolarization. Studies have shown the higher incidence of AF in diabetic patients with NAFLD. So NAFLD is associated with ventricular arrhythmia, independent of cardiovascular risk, and structural heart disease such as cardiac remodeling for the left ventricle leading to systolic and diastolic dysfunction due to heart energy metabolism perfusion. It is also linked with aortic valve sclerosis and mitral anal calcifications in patients with type 2 diabetes. Therefore, experts suggest the use of term metabolic associated with MAFLD to better describe the outcome. As we have already been um, taught about the management of NAFLD by Dr. Ashish very nicely. So we have the NAFLD diagnosis, CV screen, subclinical atherosclerosis, CVD symptoms, and we need to screen for alcohol consumption, cigarette smoking, sedentary lifestyles, unhealthy dietary behaviors, waist circumference, BMI, fasting blood glucose, especially HbA1c, blood pressure management, and so the management is avoidance of alcohol, tobacco consumptions, healthy lifestyle, Mediterranean diet, low carbohydrate, low fat diet, multimodal weight loss program, 5 to 10% of weight loss reductions, bariatric surgery, anti-diabetic medications, SLT inhibitors, metformin, GLP-1 agonist, lipid lowering therapy, antihypertensive drugs, and many others. So non-pharmacological therapy, we have been covered. Lifestyle modification, we have seen that 7 to 15% of weight reduction can reduce the MAFLD, and dietary modifications, especially the Mediterranean diet, it has been covered. It reduces the hepatic fat and improve the insulin sensitivity independently of exercise and weight loss. And we need to consult a dietitian can optimize dietary habits for NAFLD and CVD. Alcohol avoidance, exercise is the main key factor, and weight loss. And we have covered by the medication therapy. As we can see, the ASA, as known as aspirin, remains the fundamental therapy in antiplatelet therapy once the definitive diagnosis of atherosclerosis is confirmed. The preliminary research from basic and small observational studies suggests that ASA have been beneficial effect on progressions of non-alcoholic fatty liver disease, potentially reducing the liver fibrosis, which indicates the low rate of liver fibrosis and slower fibrosis progression in patients with ASA. However, these findings are not supported by randomized clinical trials. It is also not safe for the patient with esophageal varices and cirrhosis, therefore should be prescribed to patient mainly to prevent cardiovascular disease. For from mechanic standpoint, ASK may reduce the platelet activations and formation of sinusoidal microthrombi, which could limit the local hypoxia and fibrosis, like the effect of lower molecular weight heparin. Lipid-lowering drugs such as statins estimate PSK inhibitors in managing the cardiovascular events, and statins are often underutilized due to concern about liver toxicity. Evidence suggests that they are safe and beneficial even for those with elevated liver enzymes. Similarly, estimab is considered as effective for cardiovascular risk reductions through its impact on liver cirrhosis is still not clear. PCSK inhibitors so promise for patients with high CVD risk or statin intolerance, but require more research to confirm the effect on NAFLD. And antihypertensive drugs, prospective studies have shown the NAFLD significantly increases the risk of developing hypertension over time. The condition is associated with higher daytime and nighttime blood pressure levels. Connection with NAFLD and hypertension is strong, but there is sufficient evidence to favor the specific antihypertensive agent for patient with NAFLD. Beta blockers, which effective may hinder physical activity and affect calorie expenditures. Therefore, ARB and ACI are preferred due to nephroprotective properties and potential benefit for liver fibrosis. However, caution is advised in extended use solely for managing fibrosis. When significant liver dysfunctions or cirrhosis develops, the use of ACI or ARB should be re-evaluated due to potential complications. Antidiabetic agents such as metformin is the type 2 diabetes is highly relevant in patients with NAFLD, with over half of NAFLD patients having type 2 diabetes. The prevalence of type 2 diabetes accelerate NAFLD progressions and increase the risk of severe liver disease and mortality. NAFLD patients are higher risk of Developing type 2 diabetes, regular screening for type 2 diabetes in NAFLD patient and vice versa is essential. So metformin is the preferred treatment for type 2 diabetes in NAFLD due to its low cost, satisfactory glycemic control, and lack of weight gain, though its impact on liver fat and fibrosis is minimal. So we have thiazolidinediones, which is effective insulin sensitizers and help in improve insulin resistance. And other pioglitazones, all the three original TGFD drugs, only pioglitazone is still used to safety concern, and most of the meta-analysis shows improved advanced fibrosis and resolved non-alcoholic steatohepatitis. While pioglitazone remains the preferred treatment for NAFLD with type 2 diabetes, and drawbacks are there, just like weight gain, fluid retentions, and potential bladder cancer risk. So we have SLT inhibitors. Three are approved for FDA: canagliflozin, dapagliflozin, and empagliflozin, which has showed the most studies found improvement in liver fat, and one study showed improvement in liver inflammations also. So we have the GLP-1 and other more drugs on the pipeline here. And surgery is also there. The bariatric surgery is best for the NAFLD patient and CVD risk. So the conclusions, NAFLD is the most undiagnosed condition that increases the risk of atherosclerotic diabetic, and better diagnostic methods are needed. Although the fibroscan are useful for monitoring disease progressions, treatment options are limited, with lifestyle change being the key. More research are needed to find effective treatment. Experimental drugs are being developed, but many have toxicity issues. Increased better screening tool and proven treatment can help reduce the prevalence of NASH and prevent negative cardiovascular outcomes. Thank you.